The standard of care for mantle cell lymphoma in the frontline setting depends quite a bit on the amount of disease a patient has, their age, and their overall fitness. So we've come a long way, I think, in understanding mantle cell lymphoma. When it was first described, the thought was that this was a very aggressive disease in all patients. And I think what we've learned now is that there is a subset of patients that have a more indolent presentation and an indolent course. This can either be nodal, small volume or low tumor burden nodal disease, or it can be leukemic, which is more similar to CLL. And it's really important to pull those patients aside when we talk about frontline therapy because they can be safely observed for a period of time. Amongst patients with classic mantle cell lymphoma, we typically dichotomize patients between those who are young and fit, where we use aggressive induction therapy followed by autologous transplant, as well as maintenance rituximab. For those patients who are older or unfit, we typically do chemoimmunotherapy with maintenance rituximab for those patients. Now, there are some challenges to this paradigm, including the question of whether or not all patients need an autologous stem cell transplant. So there's currently a very large intergroups trial looking at minimal residual disease after induction and then randomizing those patients who are MRD negative between standard autologous transplant and maintenance rituximab versus maintenance rituximab alone. So I think we'll get some answers to those questions.